Assalamu alaikum and welcome to another video of Learn with Laraib. This is the third video for ECG, which is blood supply and MI. So we will be starting with the blood supply of heart. Just follow along with me. So this is the diagram and this is the anterior view and this one is the posterior view. So the aorta supplies two branches, which is right coronary artery and left coronary artery. So the right coronary artery supplies the AV node and the SA node along with the right atrium, as you can see in the pink color over here. The artery, which is acute marginal artery, it supplies the inferior part of right ventricle at the anterior side. Now, if we look at the posterior aspect of the right coronary artery, the pink artery over here gives off a vessel which is PDA, also known as posterior descending artery. Now, posterior descending artery may arise from right coronary artery or left coronary artery depending on the dominance. 90% of the time it arises from right coronary artery. So the PDA supplies the right ventricle, the posterior part of that. Anterior part is supplied by right coronary artery and acute marginal artery, or also known as right marginal artery. So this was all for right coronary artery. It supplies the AV node, SA node, right atrium, right ventricle, inferior wall of right ventricle through different arteries. Now coming to the left coronary artery. Left coronary artery first and foremost gives a branch called LAD, which is left anterior descending artery. It is also known as anterior interventricular artery. This might show up in exam, the name anterior interventricular artery, so do not confuse it and do not get confused. This is some other artery. It's the same left anterior descending artery. This will supply the interventricular septum, the apex of the heart, left ventricle, and the anterior lateral papillary muscle. Then the left coronary artery will then travel further and give off the artery known as left circumflex artery, which is present in the atrioventricular groove. So when look at the diagram, so in the atrioventricular groove, it travels backwards and upwards. It supplies the left atrium. The left coronary artery also gives off another branch known as OMA, which is obtuse marginal artery. It supplies the left ventricle. So the left circumflex artery mainly supplies the left atrium, and the obtuse marginal artery mainly supplies the left ventricle. So this was the blood supply of heart. Now we will go through each part and its blood supply. Please note that often in exam they ask you a question that this artery is occluded, so which area will be infarcted? If they're talking about PDA, we will go right up to right ventricle. If they're talking about LAD, we'll go up to left ventricle, and so on. So right ventricle, the anterior side, as you can see over here in pink, is supplied by acute marginal artery or the right marginal artery and the right coronary artery. The posterior, as you can see over here in orange, is supplied by posterior descending artery arising from right coronary artery. The left ventricle, the anterior part of it, is supplied by left anterior descending artery, also known as anterior interventricular artery, and obtuse marginal artery supplies the posterior part of left ventricle. Right atrium, as you can see, the pink part in the diagram is supplied by right coronary artery, and the purple part supplied by left circumflex artery, which is the left atrium. Now, a very important and high-yield point for exam is this blood supply of septum. The 2/3 is supplied by LAD, which is left anterior descending artery, or the anterior interventricular artery. 1/3 of it is supplied by right coronary artery. As you can see over here, the septum will be somewhere over here, and the 2/3 part is supplied by LAD and 1/3 by RCA. So this was about the heart supply. Also note that the most commonly occluded artery is left anterior descending artery, After that, it's right coronary artery, and after that, it is left circumflex artery. Now, coming on to MI, that is myocardial infarction. It is caused due to blockage of the heart vessels. Now, the ECG evolution will have different phases. The first phase is hyperacute phase, which occurs in minutes to hours, and the ECG shows tall peaked T waves, and it is localized over the area of the infarct. The acute phase occurs after a few hours. It shows ST elevation as well as a reciprocal ST depression. In the evolving phase, which is seen in ECG after some hours or some days, we can see T wave inversion and pathological Q wave. Keep in mind, not the normal Q waves, it's pathological Q waves. In the chronic phase, there are persistent Q waves, but the T waves may normalize. Now, moving on to NSTEMI versus STEMI. You must have heard about this term. NSTEMI is non-ST elevation MI, which is subendocardial. There is ST depression and T wave inversion mostly. In STEMI, it's ST elevation MI. That means that the ST elevation is seen on the MI ECG. It is transmural infarct. It shows ST elevation plus reciprocal depression, which is sometimes present, sometimes not. Now, coming on to a very high yield concept, which is ECG localization for ST elevation on MI. So the infarct location is always in correspondence to the lead placement and the artery which is occluded. Let's remember it by some mnemonics. So just remember V1, 2, 3, 4, 5, 6, and 7, 8, 9. It goes in that order. So let's remember the order of the infarct area by the mnemonic, which is in a Desi accent, let's call it SALIP. So S for septal, A for anterior, L lateral, I inferior, and P posterior. And the corresponding leads for septal will be V1 and V2. See the leads over here in yellow. For anterior, it will be V3 and V4, the one in blue. For lateral, it will be AVL, L for lateral, L for AVL, and the lead 1 with 5 and 6 as the number goes on. For inferior, always remember the F in inferior stands for AVF and the rest of the leads left, which is 2 and 3. Posterior wall MI is only seen if posterior leads are attached, which are mostly not. Therefore, mostly posterior MI is often missed. It can be seen as ST elevation in V7 and to V9. However, it also shows as ST depression in V1 to V3 and tall R waves in V1 to V3 as well. Now let's move on to which artery is occluded by the infarct, and this is again a very high yield question. For a better understanding, I have attached the heart diagram over here and we will be correlating it with the diagram. So septal means the septal area, which is mostly supplied by the 2/3 of it is supplied by LAD. So the lead V1 and V2 shows septal infarct, and the occlusion will be of left anterior descending artery. Now the anterior portion again is mostly supplied by LAD. So V3 and V4 ST elevation will show occlusion of left anterior descending artery. I did not consider the right ventricle much because this portion mostly comes under inferior side of the heart. Now, talking about the lateral side, if you can see it labeled over here, the lateral portion is mostly supplied by left circumflex artery. So left atrium, and this purple view is left circumflex artery. The ECG shows ST elevation in lead 1, AVL V5, V6. It means the lateral area and the left circumflex artery will be occluded. Now coming on to the inferior part, if you can see in the diagram, it mostly involves the right atrium and the right ventricle, which is supplied by the right coronary artery. So infarct of the inferior part of the heart will be due to occlusion of right coronary artery I hope you understood the ECG localization. Let's look at this ECG and try to pick up the abnormality over here. This is an ECG of MI. When we are trying to see MI, we try to look at the V leads first and then we'll go on to the other leads. So V1 shows no ST elevation. However, V2 shows ST elevation. V3 also shows ST elevation. V4 also shows ST elevation. V5 also shows ST elevation. And V6 also shows ST elevation. Okay, now coming on to lead 1, it shows ST elevation. Lead 2, however, does not show ST elevation. Lead 3 does not show ST elevation. AVF do not show ST elevation. Then ST elevation is present in AVL as well. AR is normally not considered because it is not denoted by any area. So let's correlate it. Lead 1, AVL, V5, V6. All of these are in green and the green one was lateral. V2, V3, V4, we have the blues and the yellow. So the blue one is anterior and some part of the septa is anteriorly present. So the infarct will be anterolateral. Always keep in mind that the ECG will not be exactly same as the book. There will be some differentiations. You are not supposed to write it anterior septal lateral. Some part of septa is already present at the anterior side. Therefore, V2 shows an ST elevation as well. The most of the ECG is for anterior lateral. Now, if you focus on lead 3 and AVS, it shows ST depression. This is the effect of reciprocal action. We're not required to do this in detail, therefore I'll just drop it over here. I'd like to also highlight an MCQ. It says that a man present in ER with ST depression in lead 2, 3 AVF was advised angiography. The most likely culprit is the infarct will be in the inferior wall and the artery supplying will be right coronary artery. So the correct option will be right coronary artery. I hope you understand this. If this made MI localization easier for you, subscribe and watch my other ECG videos. I've linked them under this video as well. Thank you.